Hello, welcome again. Welcome for medical students whom join us in this series of lecture in cardiovascular disease. Our lecture today is a congenital heart disease. In the first part, as you remember, we take first group of congenital heart disease is a non-cyanotic congenital heart disease with the left to right shunt. We take A.S.D, if you remember, B.S.D, and patent ductus arteriosus. While today is a cyanotic congenital heart disease, and this group, really for undergraduate, we will take only tetralogy of Fallot and the transposition of great vessels, TOF and TGA. It is enough for the student undergraduate. Others are rare. There's not a time to be discussed them. Firstly, you have to know what the cyanosis is. A bluish discoloration of skin and mucous membrane due to the increased deoxyhemoglobin. And desaturated arterial blood pressure give us as a central cyanosis, while peripheral cyanosis normal arterial saturations. Detected clinically, I mean saturated below 85% of oxygen by pulse oximetry or by arterial blood gas analysis. Causes of cyanosis, in short, there is central cyanosis and peripheral cyanosis. Central cyanosis, respiratory cause, CNS cause, muscular cause, and cardiac, our topics today. And peripheral, congestive heart failure, patient in a shock, acrocyanosis, and abnormal hemoglobin. Congenital heart disease, as we discussed in the first lecture, two types: increased pulmonary flow and decreased pulmonary flow. Increased pulmonary flow like TGA, transpositions of great vessels, truncus arteriosus, and total peripheral pulmonary peripheral venous drainage, and other. Rare. With the decreased pulmonary blood flow, the base example is TOF, and the other example. Now come to the tetralogy of Fallot, or Fallot's tetralogy. As we said, is the commonest congenital heart disease. Is the commonest cyanotic congenital heart disease, about 10% of all congenital heart disease. There is a 4 morphological defect. First, ventricular septal defect, usually big. Right ventricular outflow tract obstruction. That means at the right side, at the pulmonary valve, either valvular, subvalvular, or supravalvular. Subvalvular is the commonest. Third is overriding of the aortic arch. The aorta is opening on the left and right ventricle, overriding the septum, and right ventricular hypertrophy. For main morphological, VSD, overriding of aorta, right ventricular hypertrophy, and right ventricular outflow obstructions. Tetralogy of Fallot with pulmonary atresia in 10%. These rare, really, just to know. Rare variant include tetralogy of Fallot with the absent or dysplastic pulmonary valve, and tetralogy of Fallot common with atrioventricular canal. Also, there is pentalogy called tetralogy plus ASD. These rare, just to note. So, what the altered in the physiology in case of congenital, I mean tetralogy of Fallot? Obstruction to the flow of deoxygenated blood from the right ventricle to the pulmonary artery. This is the main physiology. Decreased oxygen saturation due to the poor perfusions of the lung. And the shunting of deoxygenated blood from the right ventricle to the aorta across the ventricular septal defect, facilitated by aortic override. Poor systemic oxygenation, low hemoglobin saturation lead to the cyanosis. So clinical presentations of tetralogy of Fallot is the onset and degree of cyanosis depend on two things: severity of pulmonary obstruction and the size of shunt, VSD. Really, these 2 points, keep in mind that they're important in the clinical presentation and also in the outcome, also in the prognosis, also in the indication of surgery. Is the severity of VSD and the size of VSD, severity of pulmonary obstructions. Cyanosis is usually not seen until 3-6 months of age. The cyanosis is due to the right ventricular outflow obstruction causing, as we said, deoxygenated blood through the VSD. Clinical presentation: cyanosis not usually notes at birth. If the child born with cyanosis, usually TGA, transposition of great vessels. Born without cyanosis, and cyanosis when the child become active, usually tetralogy of Fallot. But if the severe and with pulmonary atresia, usually born with cyanosis, could be born with cyanosis. But in general, born with cyanosis, TGA. Born without cyanosis, congenital transposition, tetralogy of Fallot. Why the child of tetralogy of Fallot and usually not cyanosis at birth? For that, the two reasons: child less active in the initial few months. Secondly, fetal hemoglobin F, has a more affinity for oxygen than adult hemoglobin. Cyanosis manifested more as a child become more active. Physical growth usually in tetralogy of Fallot look normal, but mental development may be delayed in a severe case due to the chronic hypoxia of the brain. Now come to the important point. Please pay attention. Cyanotic spill or hypercyanotic spill or cyanotic teats of newborns. This is serious and fatal sometimes in tetralogy of Fallots, tetralogy. Usually occurs when the child cries or is very active, as when the child wakes up from the sleep. In the teat spill or the hypercyanotic spill, activity results in why the child during activity developed hypercyanotic spill. Increased oxygen demand during exercise, so need of the more oxygen, and decreased systemic vascular resistance. Increased sympathetic activity with the cause infundibular spasm, right ventricular outflow obstruction more. So increase in the muscular obstruction to the right ventricle outflow at the subvalvular level, as we said, is the most common. More shunting across the VSD, more desaturated of systemic blood pressure, and which causes the peripheral acidosis and cyanosis. Further systemic due to that and the metabolic acidosis, further systemic vasodilatation, further increase in shunt, and further increase in systemic vascular and the shunt. So the child in the hypercyanotic spill enter in the vicious circle. And teat spill is most commonly start around 4 to 6 months of age and are characterized by sudden onset or a deepening of cyanosis, sudden onset of dyspnea, alternation of consciousness, decrease in intensity of systolic murmur, even fatal if not treated properly. And the hypercyanotic spill require immediate intervention because it is serious and sometimes fatal. The first step are to place infant in knee chest positions. Older children usually squat position, we will discuss squat in the next few slides, spontaneously and don't develop hypercyanotic spill usually. It's in infants. establish as a calm, main line of management, establish a calm environment, give supplemental oxygen, give IV fluid or volume expansion if the spill persists. Standard medical therapy include morphine, phenylephrine, and beta blocker, propranolol, esmolol in a drip. And if standard measure don't control the spill, systemic blood pressure can be increased with a ketamine 0.5 to 3 milligram per kg IV or 2-3 milligram intramuscularly. Also have beneficial effect sedation of the patient. Sodium bicarbonate we give in case of metabolic acidosis. What the squatting? Typical of Fallot's tetralogy, but can be seen in other congenital heart disease, but it's atypical. Child assumes squatting posture very frequently, even several times a day. Some posture may call squatting equivalent. Reason is that squatting causes an increase in a resistance, peripheral systemic resistance, to a systemic flow, so decreased shunting across the VSD, less desaturations of systemic blood flow, and less, cyanosis. The squatting position. This is that the child with squatting position really is a compensatory mechanism, increase in peripheral vascular resistance with the diminished right to left shunt and increased pulmonary blood flow and decreased cyanosis. That's why as we said, in older children, assume the squatting position less and unusual to develop hypercyanotic spill. This also squatting position in congenital heart disease, and this is a painting also correct to see that the squatting positions. Natural history of the tetralogy of Fallot is a wide spectrum from clinical manifestation, depend on the severity of abnormalities, as we said, in the how big is the VSD and how severity of obstruction in left ventricular outflow tract obstruction. That the degree of obstruction to the right ventricular outflow and size of VSD. This is important. In a severe cases, child may have repeated cyanotic spills and even born with the cyanosis, but usually born without cyanosis. In less severe cases, child may be free from spills, but severely cyanosed with a normal physical development, as we said, and delayed mental development. In mild cases, child may grow normally with the cyanosis being only minimal, and in this case what's called adult tetralogy of Fallot or adult tetralogy of Fallot. In treatment, really definitive management, complete repair of tetralogy of Fallot consists of patch closures of ventricular septal defect and widening of right ventricular outflow tract with the muscle resection and pulmonic valvoplasty. This is the main steps in the definitive treatment. If there is significant hypoplasia of pulmonary valve annulus or aplasia or atretic, transannular patch is placed. Surgery is usually done electively at age 2-6 months of life, but can be done at any time if symptoms are present or right ventricular outflow tract obstruction is severe. There is a palliative surgery. Previously, years ago, usually surgeons to start with palliation until the child grow up. But nowadays, do definitive surgery as early as you can. In some neonate with a low birth weight or complex congenital anomaly, initial palliation may be preferred to complete repair next step. The usual procedure is modified, it's a very famous modified Tossard shunt, Blalock-Tossard shunt, in which the subclavian artery is connected to ipsilateral pulmonary artery with synthetic graft. I mean, the idea behind the palliative surgery is to shunt between pulmonary and systemic circulation. There is a lot of procedure, but Blalock Tosat is the modified Tosac is as a famous one. More recently nowadays, transcatheter intervention to a stent, put a stent in a right ventricular outflow tract has been used as an alternative to the palliative procedure with good outcome. So treatment is the palliation, as we said, until the child grow well, and or to do a definitive surgery right away in the 6 to 12 or 3 to 6 months of the neonatal life. A few points about palliative is aimed to divert systemic blood into the pulmonary circulation and thus enhance pulmonary blood flow and oxygenation of the blood. A standard operation, as we said, modified Blalock Tosac shunt and other port shunt and the Watterson shunt and more recently stenting. This shunt in general do a window between pulmonary and the systemic circulation. Relief of right ventricular surgery, as we said, definitive relief, ventricular outflow tract obstruction, and the separation of the systemic and pulmonary circulations by treating overriding aorta and closure of the VSD. A treatment strategy, palliative surgery in the early childhood, followed by the definitive surgery. This is in past. In the later years, usually after 3 to 4 years, but nowadays even 3 to 6 months. Definitive surgery in the neonatal period for early childhood is now the treatment of choice. Ventricular septal defect, pulmonic stenosis, overriding of aorta, right ventricular. This is the 4 main morphological. The heart, we will show it is the boot-shaped heart, like a boot-shaped heart. And this is the ventricular septal defect and the right ventricular hypertrophy, the aorta override in the left and right ventricle, and the subpulmonic stenosis. Is the hypercyanotic spill or teeth spill in the child. Tetralogy of Fallot with bluish skin episode, crying or feeding. Teeth spill. This is another picture for them. And this is behind the idea behind the palliative surgery. He's shunting subclavian with the systemic circulations. Another, this is and pulmonary as systemic circulation. The key point, because of tetralogy of Fallots, is a large ventricular septal defect, right ventricular outflow tract, and pulmonary valve obstruction and overriding of aorta. That's right. Pulmonary blood flow is decreased. The right ventricular hypertrophic and the unoxygenated blood enter the aorta via large VSD. Manifestation depend on degree, as we said, right ventricular outflow tract obstruction, and severely affected neonate have a marked cyanosis even at birth, dyspnea with the feeding, poor weight gain, and harsh grade 3 to 6, 5, 6 systolic ejection murmur. This murmur usually disappears during hypercyanotic spill. Hypercyanotic spill are sudden episodes of profound cyanosis and hypoxia that may be triggered by a fall in oxygen saturation, example during crying or defecating, decreased systemic vascular resistance during playing or kicking legs, or sudden tachycardia or the hypovolemia. Given neonates with a severe cyanosis and infusion of prostaglandin E2, usually, as we said in discussion, patent ductus arteriosus, it's closed within hours and days after birth. But if we need it and give prostaglandin E infusion to keep its open ductus arteriosus, if we want to close it, give endomethacin infusion. So place infant with the hypercyanotic spill in knee chest positions and give oxygen, sometimes opiate, and volume expansion, sodium bicarbonate, beta blocker, phenylephrine. Even repair surgery at 2 to 6 months, as we said, or earlier if the symptoms are severe. That is, I think this is enough for tetralogy of Fallot. The second congenital heart disease, cyanotic, is transpositions of great vessels. What does mean transposition? Pulmonary artery, it's arises from the left ventricle, usually from the left, and the aorta is arises from the right ventricle. For juxtapositions and the transpositions of great vessels, TGA it's called. Abnormal origin of aorta and pulmonary artery from ventricular complex. Atrioventricular concordance, it means without the ventricular arterial discordance. What does mean atrioventricular concordance with the ventricular arterial discordance? It means ventricle arterial is the same, but not with the artery. Left atrium, left ventricle go to the pulmonary. This do a problem. While the right atrium, right ventricular discordance with the arterial, so to come to the aortic artery. Abnormal spatial relations of great arteries result in two circulation parallel. P thinks there is two circulation not mixed. 5 to 7% of all congenital malformation. So transposition of great TGA, aorta arises from right ventricle, is the anterior and the right of pulmonary artery. Pulmonary artery arises from left ventricle. Total separation of pulmonary and systemic circulation. Please think is in a parallel circulation, not mix. This is a problem. If there is no mix, the child will die within a few days. Need shunt to survive following birth. The child, if birth without shunt, it will be die. If there is shunt, there is two types of shunt. Stable, like ASD, VSD. This is stable shunt and still some of deoxygenated blood from oxygenated from the lung and go to the systemic circulation. Without this shunt, it becomes parallel and not mixed. There is unstable, shunt, like patent ductus arteriosus. Why unstable? As we said, it will close in a few hours and days. Foramen ovale also. Unstable shunt close quickly after birth, so the child needs surgery. The aorta, to look here, aorta is originated from right ventricle, so most of the blood returning to the heart from the body is pumped back out with the first going to the lung. The pulmonary artery originated from the left ventricle, so that most of the blood returning from the lung go back to the lung. Look, this is the normal, the aorta and pulmonary. This is the transpositions of great vessels. So parallel circulation, not in serious. Look, please, from the body to the right atrium, right ventricle. They say there is concordance, but supposed to be here aortic and to the body, while the left atrium, left ventricle, supposed to the aorta come to the pulmonary and to the lung. So body, right atrium, right ventricle, aorta, and come to the body again. And this is the oxygenated blood. This is to the systems and to the lungs. This is oxygenated blood. This is unoxygenated blood. If there is no mixing, the child cannot live. If I do mixing in atrial, septal, this is what called stable, or TGA, patent ductus arteriosus, or foramen ovale, unstable. Poor mixing and hypoxia, acidemia, hyperventilation, increased pulmonary blood flow, congestive heart failure, myocardial depression. Look, please, from the body to the right atrium, right ventricle, pulmonary artery, and to the lung, and to the left atrium. This is normal. Normally, if we look. In the tetralogy of Fallots, in the transposition of great vessels, from the body to the right atrium, to the right ventricle, to the aorta, to the body. And in the lung, it will circle here, unless there is some shunt. These congenital anomalies, please, just to know, it's not important for, it's rare. And this rare, I say this rare, it's not for a student undergraduate, but just to know there is other congenital cyanotic heart disease. Truncus arteriosus, I come across rapidly that the pulmonary and aortic arch come in common and from the left and right ventricle. And single ventricle, this is the normal right, left, this is a single ventricle. And the total pulmonary venous drainage, you know pulmonary, it come to the right atrium. In total anomalies is come into the left side, either superior, inferior vena cava, at what different level. And the tricuspid atresia, usually there is atretic tricuspid valve. And this is the normal this atretic tricuspid valve. Usually the baby cannot live without ASD or VSD. And the Epstein anomaly, look to the normal right left ventricle. Here the right atrium is become big. Some atrialization of the right ventricle. Most of right ventricle atretic and right atrium is and big. Also rare. We give you some X-ray, interesting X-ray for the congenital heart disease. This is what called eggs on a string sign and transpositions of a great vessels. This means eggs on a string sign in the transpositions of a great vessels. And the total anomalous pulmonary venous anomalies is the snowman sign. This is a snowman sign. Total anomalous pulmonary vein, usually here, but it is to the right side of the heart. Other interesting X-ray is the pulmonary venous return called scimitar sign. Scimitar, it means a short, curved sword, like al-battar in Arabic, scimitar signs. This scimitar sign in the partial anomalous of this is a scimitar sign. Look to that if we come, this is a scimitar sign. In the partial anomalous, this is the scimitar sign. And endocardial Cushing defect is the goose necks. And this is the goose neck in the Cushing defect. And in the tetralogy of Fallot, as we said, is the boot-shaped heart. Boot-shaped heart. Coarctation of the aorta is the reverse. In the coarctation of the aorta is the reverse figure 3. Look to that there, or from the other side. In coarctation also you see there is that the correlation, I mean this is that the aorta is severely narrowed just beyond the arch to start the descending the aorta, upper median. Extensive collateral dilatation. This is intercostal, usually the cause of rib notching. This is extensive collateral. While in the Epstein anomaly is look like box, what called box shape, Epstein anomaly. See you soon. Thank you for participation.